Today we're going to be talking about peptic ulcers. Peptic ulcers are sore or lesions that develop in the stomach lining or proximal duodenum, which is from the discontinuation or damage of the inner lining of the gastrointestinal tract, primarily from excessive gastric acid secretion, or pepsin, which is a digestive enzyme from stomach, which is primarily used to break down proteins into polypeptides. The ulcers can extend into the muscularis propria layer of the gastric epithelium. Peptic ulcers have two most common causes. Firstly, Helicobacter pylori, also known as H. pylori. Next most important is non-steroidal anti-inflammatory drugs like aspirin and ibuprofen. Peptic ulcers can be a very serious, deteriorating and possibly life-threatening medical emergency that can present with these symptoms. It's essential to understand the pathophysiological in a pre-hospital setting. The stomach sits on the upper part of the abdominal, specifically sitting in the epigastric left hypochondriac region and umbilical region. It produces enzymes that create chemical reactions and acids breaking down food. The top of the stomach connects to the valve called the esopharyngeal sphincter, and the bottom connects to the small intestine. The stomach includes 5 parts: the cardia, which is the top part, the fundus, which is the rounded section, the body or corpus, which is the largest main section where the stomach contracts, the antrum lining, which holds the food before it goes into the small intestine, and the pylorus, which is the most bottom part, including the pyloric sphincter. The duodenum is the beginning part of the small intestine. Positioned inferiorly to the stomach, it is about 25 to 30 centimeters long. It contains 4 parts: the duodenum bulb, connecting to the undersurface of the liver via the hepatoduodenal ligament, containing the portal vein, hepatic artery, and common bile duct. The second, descending segment, is above the right kidney. The third segment runs in front of the aorta, and the fourth segment continues as a jejunum. The primary arterial blood supply to the stomach and duodenum comes from the celiac trunk, which branches into the left gastric artery, the splenic artery, and the common hepatic artery. The stomach stores and digests food and liquid we intake. It produces hydrochloric acid, which helps in the digestion of food, killing foreign substances like bacteria. It absorbs minerals like phosphate, calcium, and iron. The stomach muscles contract, churning food, making digestion easier. It releases enzymes like pepsin secreted by sheath cells in inactive zymogen called pepsinogen. Other enzymes include gastric amylase, gastric lipase, which also helps in the absorption of proteins, simple sugars, and lipids. The stomach has several layers: the mucous membrane tissue, which covers the inside of the stomach, the connective tissue containing blood vessels, nerves, and mucous tissue, and mucous tissue. This layer is made up of 3 sublayers that pull the stomach in different directions, which help with the churning. There are multiple small glands in the lining of the stomach. They produce digestive enzymes and hydrochloric acid. Digestive enzymes split up the proteins in food. In addition to this, small glands produce a thick protective layer of mucus that prevents the acid from attacking the wall of the stomach. This contains a lot of bicarbonate, which is alkaline, which neutralizes the acid in the stomach before it reaches the wall. Prostaglandins, particularly prostaglandin E2, serves as a protective barrier by stimulating the production of mucus and bicarbonate. It also benefits the stomach by regulating blood flow to the stomach lining, ensuring oxygen and nutrient supply for repair. This is vital when discussing peptic ulcers. The duodenum continues the digestion process that initially started in the stomach. Chyme is made in a valve between the stomach and the duodenum called the pylorus. Digestion inside the duodenum is facilitated by digestive enzymes and intestinal juices made by the intestinal wall. This also includes fluids from gallbladder, liver, and pancreas. Importantly, the duodenum regulates the environment from secretin released from the duodenum epithelium, which is released when the pH of the duodenum decreases. Secretin neutralizes the pH of the duodenum by stimulating water and bicarbonate secretion, aiding in digestion. The duodenum also has a mucus protective layer from stomach acid and has a rapid cell turnover, which means cells are replaced frequently, helping with repairing damage. The stomach and duodenum is essential in the digestive system. They work together to break down food and absorb nutrients. It is essential to maintain key processes to ensure a healthy digestive system functions appropriately. When external and internal factors begin to disrupt this process, diseases and complications arise. Both duodenum and stomach have multiple control processes. The cause of the ulceration can differ in individuals, as there is not one single cause for peptic ulcers. It is evident that the majority of peptic ulcers are a cause of either NSAIDs or H. pylori infection, all of which cause a degeneration of mucosal layer. Non-steroidal anti-inflammatory drugs cause a significant amount of peptic ulcers. This is due to the inhibition of prostaglandin production. Prostaglandins are responsible for the production of mucus and bicarbonate, which protects the stomach from acidic drugs. NSAIDs inhibit this prostaglandin biosynthesis, which occurs when the arachidonic acid is converted into cycloogenase, COX enzyme, after cell injury. COX-1 is present in endothelium, GI tract, and platelets. They activate and often very important for physiological functions. The gastric and renal toxicity of NSAIDs are often related to the inhibition of COX-1 enzyme. COX-2, limited but induced during inflammation. Inhibition of this enzyme from NSAIDs causes a therapeutic and anti-inflammatory analgesic effect. NSAIDs inhibiting COX-1 in the gastrointestinal tract lead to a reduction of prostaglandin secretion and its cytoprotective effect in the gastric mucosa. This increases the susceptibility to mucosal injury. It does this through impairing the transformation of arachidonic acid to prostaglandins. NSAIDs are non-selective drugs, so affect the COX-2 enzyme, but gastric ulcers are primarily occurring due to the effects of COX-1. It is important to consider that alcohol irritates stomach cells, causing inflammation, causing gastritis. Taking NSAIDs with alcohol exacerbate the risk of developing peptic ulcers. H. pylori can be spread from person to person eating food that's not clean or cooked safely or water with bacteria inside. H. pylori causes inflammatory response in the neutrophils, plasma cells, and macrophages within the mucosal layer and causes epithelial cell degeneration and injury. The damaging of the protective mucous layer of the stomach and duodenum allows stomach acid to erode the tissue underneath. The bacteria's CAGA oncoprotein trigger chronic inflammation and activates immune system, which releases inflammatory chemicals to kill bacteria, but this can damage the mucosal layer. H. pylori releases urease, an enzyme that breaks down urea in the stomach to create ammonia. This ammonia creates a less acidic environment around the bacteria, which helps them to survive. The VACA causes cell death and suppression of lysosome function in epithelial cells, which stops the removal of dead cells. Bacterial proteases and lipases degrade the mucosal layer, affecting the phospholipid layer, protecting the endothelial cells. H. pylori impairs the secretion of bicarbonate, thus increasing acidity, so once the mucosal layer is inflamed and damaged. Both the direct cell damage from bacteria and the inflammatory response can compromise the mucosal layer in the stomach and duodenum. This is where the mucus layer gets damaged, resulting in peptic ulcer formation. Other causes include infections, which have a very similar effect to H. pylori. Medicines, like corticosteroids, medicines to treat bone mass, and some antidepressants, will have a very similar effect by inhibiting prostaglandins. Surgery can cause direct damage to stomach and duodenum tissue, which expose area to acid and bacteria, for example, a gastric bypass. Medical conditions like Crohn's disease cause chronic inflammation and damage the GI tract. Radiation therapy and chemotherapy can damage stomach lining too. Zollinger-Ellison syndrome, although rare, can also cause tumours forming in stomach where it overproduces acid. The acid leads to very severe peptic ulcers. Untreated peptic ulcers can cause upper GI bleeding, gastric outlet obstruction, perforation, penetration, and gastric cancer. The dull burning pain in stomach is from the acid and digestive enzymes coming into contact with the ulcerated area. Fullness or bloating is inflammation, scarring, or muscle spasms. Excessive belching may occur due to extra production of gas. Similarly, the excess stomach acid can irritate the esophagus, causing heartburn. Vomiting is from inflammation and stomach contractions. Additionally, perforation could develop vomiting, causing vomiting and nausea, and this can bring up blood. This can also be from abnormal food movement through the GI tract. Blood and stool and dizziness can be a sign of bleeding from upper GI tract. This includes a blood pressure drop. The coffee ground vomit is from blood from the ulcer that gets exposed to the stomach acid for long periods, where acid breaks down the hemoglobin in the blood, changing colour from dark brown or black. Pre-hospitally, the focus will be looking for key signs and symptoms for suspicion of peptic ulcers, like bleeding, perforation, vomiting blood, dark stool, severe abdo pain, and a drop in blood pressure. Pain medication like opioids might irritate GI tract more, similarly to paracetamol, but it's essential to not give NSAIDs. Someone experiencing peptic ulcers at a severe level might be internally bleeding, which could show signs of hypovolemic shock, including fast, weak, cool, pale, shallow breathing, clammy skin, decreased GCS, confusion, low blood pressure, weakness, and decreased urine output. In this case, it is essential to treat symptoms like blood pressure with fluids and, most importantly, rapid transport to hospital. Antacids can provide quick temporary relief, but will need hospital intervention. It is essential paramedics have a comprehensive understanding of the GI tract and anatomical locations to ensure the patient is receiving the most optimal treatment and possible risk factors can be identified. Understanding stomach and duodenum vascular supply, like the left gastric artery or gastroduodenal artery, is essential to understand so we know why ulcers hemorrhage. Circular assessments and vitals are utmost important here. Knowing about the effects of H. pylori and NSAIDs can ensure paramedics are making essential links between patients' history and their presenting complaint. Understanding that severe visceral pain can activate the sympathetic nervous system, showing signs like tachypnea, tachycardia, and diaphoresis. Paramedics need to know what peptic ulcers could lead to, for example, hypovolemic shock, septic shock, and ulcerations going into bacteria into the blood. Understanding the life-threatening risks associated with peptic ulcers and the need for immediate transport. Having a fundamental understanding of peptic ulcer pathophysiology to make a provisional diagnosis can save patients' lives and give them the most optimal outcome. Here are references.